Hello, Stephen, Michael, Peter, and everybody. I'm very sorry I'm not there with you today, but I want to spend a few minutes telling you how we're going to 3D print the future. Just going to share my screen and let's get on with it. So with technology, we can, I think, print the future and prevent the need for total joint replacement. Aging happens to us all, whether you're a member of the royal family of one sort or another, or just a commoner. Here's one sort of royalty, one of the greatest athletes that's ever been. Sadly, having had a great time, he's worn out. This is a member of our royal family who didn't wear out till he was in his 90s, here enjoying his own chosen sport, some 4 years after I had replaced one of his joints in his mid-90s. And this is a picture of another sort of royalty. This is dear Stephen. Here he is in the gym, having fun, aged 89, 10 years after a bit of wear in his knee. Now, normal knees aren't straight. Slightly bowed is normal and indeed athletic. Slightly knocked knees we see in supermodels, sashaying down a catwalk. And both of them have different loads put across their body with predictable failure patterns. So this is Emma Raducanu, who is obviously an amazing athlete right now. But this bowing of her leg means that I'm quite sure she won't be able to last as long as Roger Federer on the tennis court because of the excessive loads. And these knees in high heels have a different load. They actually overload the outsides of their knees. So this is the typical athletic failure pattern that I'm afraid Emma will definitely suffer from. And I expect quite soon because she's such a good athlete. And this is the supermodel disease where the lateral compartment, this is also interesting enough for people in Gestad. This is what happens from too much skiing. And the lateral meniscus fails and the joint wears out. We can now use 3D analysis from very low dose CT to automate the measurement of each little part of the knee joint and actually describe the different parts of the knee that go on to wear out. And what we find is that the athletic child squashes their medial femoral condyle slightly. So this inside of the knee gets flattened. And by flattening both the femur and the tibia, we end up with a flatter joint rather than that spherical joint. And the flatter joints just fail faster than the spherical ones. So by being a good athlete in childhood and adolescence, a lot of exercise causes that deformity, which predisposes to arthrosis, to wearing out. Knowing that, now 15 years ago, we developed a very low-cost robotic platform that allowed us just to reline that little part of the knee with great accuracy and precision. A real revolution back then. This technology platform then lets us go on to do much more innovative things. Now, 10 years ago or so, we started putting back veterans together using this technology platform. So here's a man who was shot in Afghanistan. In fact, it was a friendly fire incident, but lost a great big bit of the inside of his knee, being put back together with 3D printed titanium on the inside of his knee. And this man was shot in Iraq. And here we had to, rather more challengingly, 3D print plates to correct the deformity, as well as a part of his knee. This man was still in his early 30s, terribly damaged, but mercifully we can achieve really fantastic results with minimal surgery using this platform bed. And the real transformation is a 3D printer. This, with a 3D printer and an engineer, we can achieve plans with robotic level accuracy, but at low cost, both in time and sterility. And this is what you really need, which is a brilliant engineer to write the code to drive the printer. And Susanna here is designed this little bit of nylon that fits perfectly onto the body, and armed with describing the shape, we just have to change the exact dimensions to change from one person's shape to another. And this is a bit of software that actually inputs just a range of digital inputs, transforms it through the 3D printer. Here's D with a printer. We get a knee in a box that for one person will be obviously slightly different from another person, but the software just allows you to flip from one person to the next based on the coordinates from a CT scan. And this gives you robotic level accuracy. Here's a case from last year of a man who, aged 11, had his femur broken by a motor car. He was on a paper round and he was knocked down and lived with this bent leg all his life, and increasingly worn out inside the knee because of this bowing caused by a fracture. This metal plate, which had been in for 50 years, was actually inside the bone, so we couldn't take it out. So Susanna and her team designed, with a bit of surgical interaction, a corrective procedure to straighten this bent leg at the same time as relining the worn out part of the joint. So with this bit of 3D printing technology, we can perform a combined corrective osteotomy and realignment of the operation. And I think we're still the only group in the world to deliver that. So this allows us to address the compartmental approach to the knee rather than just cutting out the whole knee on site, which has been how many groups in the world have addressed wearing out. They just say it's a disease, we're going to cut it out, and that'll be the end of it. And so with this technology, we've been allowed to either, just in this case, reline the inside of the knee and the patellofemoral joint, but leave the outside, and of course the ligaments, importantly the ligaments. Here's a similar case. This is one a bit like Michael's I described earlier. And then these two knees, these belong to the same woman. And this is a catwalk model's disease. This was actually the wife of a knee surgeon. He actually only did total knee replacements, but he didn't want his wife to have a total knee replacement. And so he brought her to me, and we just did lateral unis and patellofemoral joints, because our patellofemoral joints were very bad too, keeping importantly our cruciate ligaments and her medial compartments. And if the cruciate ligament's gone, you can actually reconstruct that at the same time. Chronic cruciate ligament rupture, you often need to do a bi-uni at the same time as cruciate ligament reconstruction in someone who's got arthrosis, but obviously wants to avoid a total knee replacement. Why do you want to avoid a total knee replacement? Because the more of your body you keep intact, the better. And really, essentially, it's all about that anterior cruciate ligament. In a series of cadaveric experiments recently, we took motorcycle dispatch riders here with perfect knees. I think even in Switzerland, we have motorcycle dispatch riders who are become organ donors. And importantly, it's these anterior cruciate ligament here that really does determine, or the anterior and posterior cruciate ligaments determine the stability of the joint. And in these series of experiments, they had first of all a lateral uni, and then a lateral uni with PFJ, and then a total knee, or the other way around, at the medial side, or the bi-unis. And when we tested these people, this is the normal, this is laxity here. This is the normal level of laxity in a joint. And all of these combinations were near normal, unlike the total knees that were very far from normal, very far from normal. So this is why we're trying to avoid the total knee replacements. And we're an exciting project going forward where we may be able to avoid metal as well, simply relying with ceramic and high performance polyethylenes. So that's an exciting domain of knee biomechanics, where deformity, appreciating deformity and technologies deliver exciting opportunities. I want to change the scale now and talk about bone at a totally different scale, and microcracks. Microcracks completely undetectable on X-ray, completely undetectable on CT, only detectable on micro-CT. And we, among other groups around the world, have been measuring these microcracks. And the reason was, literally 10 years ago, 2011, the first woman who was our index case came into hospital. Now, she'd been to see her GP, and she said to her doctor, "My femur is going to break." Now, I don't suppose anybody listening today has ever had that experience. She had a history of breast cancer in the past. She was tender in the thigh, and her GP sent her for an X-ray. It was a normal X-ray. 3 days later, she went to hospital saying, my femur is going to break. They repeated the X-ray. It was normal. Because she was insistent and she'd had breast cancer in the past, they did an MRI scan. That was also normal. But that night in bed, because she wouldn't go home, she refused to leave hospital. In bed, her femur broke, rolling over in bed. Now that is not something that normal bones do at all. But the reason that Pat knew it was going to happen was it had happened on her other leg before. And she'd been told that that was breast cancer, but in fact, it wasn't breast cancer. These were two bones with pathological fractures. The fractures had occurred because she'd been taking a class of drugs called bisphosphonates. And those bisphosphonates are given to people to prevent fractures. But actually what they do is they stop bone turnover and allow microcrack accumulation to occur. So Richie Abel in my lab has been looking at the material properties of these microcracks. As I say, you can't detect them on CT scanning, but if you take a small segment and put it into a micro CT scanner, you see these increased density of microcracks. But not only are there more microcracks, if we take small sections of bone and we load it up. So here in this experiment, Richie took small segments of bone and crushed them. And what we find is that the apparent strength, which is the actual strength of the core, obviously goes down between healthy people, people who've broken a bone, and people with bisphosphonate bone, weaker still. But the really important thing is the quantity, the strength per unit volume is dramatically lower. People with osteoporosis have got less bone than normal people, but the main thing is, but it's normal bone, it's just less of it. People with bisphosphonates have much weaker bone. When you load it up like this, it may look good, but it's much, much weaker. And here is this in graphical form, where you see a stress strain curve. As you load up bone normally, you increase deflection as you load it up. And this is true with bone, osteoporotic bone that's broken but didn't have bisphosphonates. People on bisphosphonates have completely different material properties. And wasn't clear from this series of experiments where that difference came from, whether it was from the mineral, the hydroxyapatite crystals, or from the collagen fibrils. And what Richie's recently been doing in the synchrotron is using diffraction. So the synchrotron, and there's obviously the biggest in the world here in Switzerland, accelerate particles through this, focus them through a tiny fragment, and then allow us to magnify up and look at the spectrum given by these fragments of bone. And this is at a very, very tiny scale, looking at the fibrils of bone and mineral platelets. So here are the collagen fibrils and mineral platelets, and looking at the diffraction pattern. And what Richie is showing now is that it's actually the bonding between the platelets of bone and the platelets and the collagen fibrils that changes with those bisphosphonates. So they stiffen and cause fractures to propagate. This is a really scary, I think it's quite scary actually, because we've now got this huge group of patients being given bisphosphonates by experts, and rather like the opioid story that we all read about last year, or over the last few years, this huge class of drugs has been prescribed in enormous quantities. They have a half-life of decades. There's no antidote, and you can't measure how much is inside someone's body. So this is a really exciting field of research, both for the poor people who are on bisphosphonates, but also if you want to stay strong and young and healthy, how do we do that without resorting to drugs that may have long-term side effects? And I think there's a skeletal HRT opportunity to keep people young and healthy. But that's an exciting and interesting domain at a totally different scale. Lastly, I'd like to talk about the hip joint, a very different sort of joint. And to start with another tennis player, Andy Murray, who in his 20s was already suffering with his hip. And a similar sort of pattern emerges in the hip as in the knee I described before. So this is from the newspapers. I haven't treated him, so this is, no, I'm not betraying any confidences. But here, here's his resurfaced hip. But if we look at the other one, do you see how this flattened hip here, this isn't a normal hip. This wearing out of his hips happened through overuse in adolescence. And this is, I think this picture is the most helpful one here. You see this wear scar developing on a flattened bone. If it had stayed spherical, if he'd stayed in the music schools playing the cello, as his mother asked him, instead of running around the tennis court, he wouldn't have worn out like this. Of course, he wouldn't have been a sublime tennis player either. But this wearing out is just machinery failure. And when we measure these things, we can find the perfect hip is perfectly spherical, both on the acetabular side and the femoral side. These cam-type hips, like Andy Murray, are flattened on the femoral side. And there's another group where the hip goes too far in, where the hip can actually pinch. And these are fundamentally different sorts. We can use 3D modeling to show this. And we can even take hips like Andy Murray's and describe what we have to do to make it spherical again, to try and prevent it going wrong. This is difficult surgery. Andy had it and it didn't work for him. It's very difficult, but it's work in progress. Importantly, it's not just about the hip, it's also about the relationship between the hip and the spine. If you look at this picture here, this patient, when they stand up, they have this nice lordosis in their spine, and when they sit, their spine flattens out. Now, if you've got this nice mobile spine, your hips don't have to work very hard. And so you can really, these hips like these are protected by a mobile spine, whereas this person's spine is not mobile at all. And so their hips have to work harder. And if this stiffens still further, it's likely this hip will wear out because of the stiffness in the spine. And here's somebody whose hip replacement wore out because his spine was fused. So we know there's a real relationship between the spine and the hips, and overuse in adolescence determines hip shape. This is an interesting duality, I suppose. Armed with this knowledge, we set about some years ago, this is from my team, but several members of our group, 3 engineers here, 2 computer scientists. We realized that Andy Murray's operation, hip resurfacing, was good, much better than total hip replacements, but in women in particular, where this shape overhang and cause trouble. So we set about designing away the contours and getting rid of the metal lines. We set about this a long time ago. It took almost 9 years to get into first in human, and now we're 4 years into a clinical trial. We use ceramic from Germany. It's the best in the world. They've got almost a global monopoly supplier. Coatings from just outside Zurich. They've been around now for 40 years. And this combination extensively tested for, this is not 3D printed. You can't 3D print and then fatigue test to 20 million cycles. This is industrial printing. The shapes came, as I say, from our work in 3D printing, looking at the shape of the acetabulum, getting that right so the psoas doesn't get irritated, making sure that we've got the wear prevented, but no impingement. And then on the femoral head side, avoiding this overhang to allow the psoas to be relieved. And this has to be manufacturable, of course, in a ceramic, which is pretty hard to do too. And then the coating onto ceramic, that is new and exciting. So with that, 3D printed instruments really can transform things. So we've had 3D printed instruments just using a minimum amount of metal, mainly nylon. And then this single-use instrument set, here's colleagues from Japan and Germany in the lab learning how to do the operation. This is minimizing inventory costs, brand new each time, works perfectly. The last element of this is 3D printing personalized guides in addition to disposable. So here's a man with a very badly damaged hip, still in his 40s, here's our preoperative plan, and converting his preoperative plan into accuracy with just a little bit of nylon, tiny modifications based on his own anatomy, allow us to get it exactly right, robotic accuracy with a tiny bit of nylon. So I hope I persuaded you that there's some exciting opportunities, certainly the knee and the hip, for 3D printing, and some exciting nano opportunities in the skeleton. How do we achieve this? I think we achieve this with teams. I'm an absolute believer in teamwork between engineers, scientists, and surgeons. Together, we can deliver the next generation of novel devices. Thank you very much for your attention.